Welcome back. I will chair the first session. My name is medicinsk-etiska. I think I met most of you yesterday. And I had a very nice day yesterday. I think we had a lot of fun discussions. And I hope we will have it today too. And I really enjoyed the dinner and talking to old friends and new friends. And I hope you too, often when you are supposed to say something, I should speak for all of us, but I don't know what you think, so I just say what I thought. I had a pleasant time. And so let's get starting to start today. And our first speaker is an old friend of mine, Baruch Fischer, who is professor of psychology at what university is it? Carnegie Mellon? I'm just joking. Carnegie Mellon University in the United States, in Pittsburgh. And we have tried to find a title. And Baruch finally decided on a title, and you will see it soon. But the title in the program is not correct. The previous program is not correct. You will see it now. But one thing you should do is to find an old paper that Baruch wrote in 1975, which is a gem. It was for many, many years the most quoted and cited paper in the Social Citation Index. And the title is Hindsight is Not Foresight. And I think that we can, when you read it, we shall not go through it now, you will learn things that are important for what's going on in medicine, but also for what we are doing in the type of committees that we are sitting in. That is how we learn from our previous mistakes and previous successes, and how we can use them to predict. Okay, Baruch.
Okay, thank you. I'm very happy to be here. I hope I can be of some help to you. When I was in graduate school, the field that I identify with, which is now called decision science, barely existed. And among the few people in the field were Swedes who were in the leaders. So for a hick from Detroit, I read papers from exotic places like Stockholm, Göteborg, Lund, and Umeå. And then about 10 years later, I had the good fortune to spend half a year in Stockholm. We lived in the Wenner-Gren Center. My daughter Maya went to Matteusskolan, and I was visiting my friend Ulla Svensson. And during the time we were here, he used his contacts with the Swedish Radiological Protection Authorities, brought him and then brought me into dealing with the question of how to deal with domestic radon, which Sweden was sort of ahead of the world in dealing with the problem where there's some consideration at that time of setting domestic standards that were 10 times higher than the standards in occupational exposures. And for me, it was a kind of a turning point in my career in realizing what were the possibilities of working directly with people who had to solve the problems, and also in thinking about this meeting, what are the things that sometimes are possible in smaller countries, where sort of a strategic advantage of smaller countries where the people know one another, and particularly if you have a kind of civil society, people can do things collaboratively that you can't do in a very large country where the disciplines are balkanized and people from one sector or one political party don't talk to one another. And that now I have a project with Niels Erik and his colleagues. So in thinking about what I might pull from my experience that might be useful to your important work. So in some sense, following from this experience, I've had the opportunity to work on many applied problems, where one of the questions that also comes up is when have we done an adequate job of communicating with the people whose welfare is at stake? And so I thought I organized my remarks around what might be performance standards for ethical communication. So let's see. Okay. Yeah. half of my appointment's in engineering, so I was able to go from here to this. So one can think of two aspects of communication. One, what's the content, and second is what's the process by which the content is developed. One might argue, I would argue, that the content of a communication is adequate if it contains the issues that are material to effective decision-making. So the people who have to make the decision know what are the relevant facts, and as well as know what are the ethical issues and alternative perspectives on them. That the decision makers can access those issues, so it's not hidden in plain sight, but people can find perspectives on these issues, and that people understand what's being said and know how much confidence to put into the best available opinion on those issues. Performance standards for the process of decision-making. One could say that the process is adequate if it reaches decision makers early enough for them to affect their options, if it prepares them for the range of possible outcomes that might come from their decisions, and if the communication process, this two-way communication, respects their autonomy. So I'd like to go through, elaborate on each of those. So the communication process. So this is what people, and one of the things that people in my discipline do is worry about the content of communications. So it's straightforward. We have ways we have methods for dealing with it, but the logic of what we do is the logic of what people do in communication. Try to find which issues are most relevant to the choices that people face. So as scientists, there's lots of things you can tell people about a particular issue, but not many of them may be particularly pertinent to their decisions. And if you drown them in irrelevant information, then the window of opportunity for communication is likely to close quickly. Second, find out what people already know. So don't waste their time by telling them things that they know. It shows disrespect. The window of communication is likely to close further, and then design communications to fill the critical gaps, evaluate to see how well you've done, and then repeat as necessary until you've fulfilled your duty to inform. My colleagues and I have applied this basic scheme, trying to develop basic methods and some theory on a variety of different topics. Each poses some challenges. Each requires consultation with people who make the decisions, because we can't read their minds, and with people who know about the subject matter expertise, which we rarely know. If you're interested in resources in this science, our Food and Drug Administration has a risk communication advisory committee that I had the opportunity and honor to chair for its first 4 years, and we pulled together a evidence-based user's guide for communicating risk and benefit. The chapters are all 3,000 words long. They're structured. You can download it for free. In fact, FDA couldn't figure out how to sell it, so it's only available for free. Another source, our National Academy of Sciences has hosted 2 Sackler colloquia on the science of science communication. So this is not helping scientists to tell their story, but trying to extract and communicate the science that's relevant to people's decisions. Each of those has a special issue of the Proceedings of the National Academy of Science. Again, these are available for free download. Here's the first. Here's the announcement for the second colloquium, and then here in the slides, I put a bunch of URLs in the slides. You can ask them from me or get them from the organizers. This is also available for free. So part of our effort was to make the science available to decision makers or people who don't have a full communication staff. The other part of it was to draw people who are accustomed to doing basic science to think about these more applied problems. So we have some excellent social and behavioral scientists who had not actually thought about this particular challenge before. I have a paper in each of them, one on the overview and then a second on the more specific question of communicating scientific uncertainty, done with my colleague Alex Davis. There are many good examples out there of good good communication. Here's one. The Royal Society in 2011 had a workshop on communicating scientific uncertainty. There's a terrific article by Phil Campbell, the editor of Nature. Here's another paper written by people from the Bank of England trying to communicate uncertainty. I picked it. I think it's a nice figure, and I picked it because it fits the theme of the conference. So they have an obligation to communicate their projections about the future of the British economy, among other things. This is the way that they chose to represent uncertainty. For someone who's accustomed to probability distributions, it works well for me. You see greater uncertainty as you go out into the future. It's an empirical question whether it works for people who are unfamiliar with probability distributions. One nice thing that they do is that they have uncertainty about the past as well as about the future. So I don't know what the norm is in Sweden, but in the United States, you'll hear that we have adjusted the estimate of unemployment or GDP for the previous quarter by a certain amount as more data come in. And according to the Bank of England, you can continually adjust it because we never quite knew where we were. So even in hindsight, there's uncertainty. Here's another communication that I like, which does have empirical evaluation. It's done by Lisa Schwartz and Steve Wolosha, and they're internists and the couple at the Dartmouth Medical School and the Veterans Administration, who've been working for many years to make information about pharmaceuticals available to physicians and to the public in general in accessible terms. They just hosted a conference in Washington last week on, I think it's called over-medication and over-diagnosis, about people being treated for things that they don't really need for which the treatment, if they understood what the treatments were, they probably wouldn't take them. So the features of this communication, this is a drug fact box. It's patterned after the nutrition fact boxes. The principles that guide it are principles that we help them some that are based in the science of decision making. So it's to use analysis as an aid, not to replace judgment. So this is to help people along rather than tell them what to do. An attempt to quantify each benefit and risk to the extent possible. So don't say, this is a rare side effect, or this probably will help you, but tell people what the magnitude of these effects are. Do not seek a common metric of benefits or risks. So there, you well know there are people in the medical field who would like to quantify everything in qualities, and their judgment is better to tell people about the outcomes in the units in which they formulate their lives rather than to try to find some common metric, acknowledge the uncertainty, and try to facilitate individually sound choices, recognizing that different people may make different trade-offs. If you look back at this, just to show you how these things are, so on the left-hand side, what was that, chartreuse? I think that's chartreuse. In the chartreuse area, it has the different outcomes. This is for a sleeping pill. You can't read this here, but this is for a sleeping pill. So the outcomes are, the benefits are how quickly people fall asleep and how long they stay asleep. The columns are for using this pill, and for I think this one is with placebo. It gives uncertainty in there's like maybe that's magenta, a little bar towards the top. It tells you what the evidentiary base is. So it said there was a clinical trial with, I think it's 986 people who were taking no other medications and did this for 6 months. So it doesn't tell you exactly what the uncertainty is, but if you thought about it, you could say, well, this won't pick up rare side effects, it won't pick up drug interactions, it won't pick up problems with continued use. So it gives people some feeling for the quality of the evidence that they're doing it. It doesn't tell you what to do. That's your choice. Some people may want to take the risks that are on the bottom part of the table in order to fall asleep several minutes earlier. Okay. In terms of the process, so what do we know about what's the science that enables us to achieve these performance standards in terms of the process? So this is more a social science than a behavioral science question. So here I'm bringing forward the research that other people that I know. You'll find many there are many people who have advocated a somewhat similar approach. There are documents from many countries, the OECD that have the same basic picture that is consistent with the research on participatory processes. The one I like best is from Canada. This is a national standard of Canada from the Canadian Standards Association. So this is a picture. In the middle, there's a standard project development process. You initiate your process, you do some preliminary, you define your problem, you do some preliminary analysis, and then you go through and eventually you take some action and then monitor your actions. Significantly, in this Canadian perspective, there is risk communication all the way along, connected by two-way arrows. So it says, well, before you start managing a risk, listen to the people who care about it so that you define your problem. You have the best chance of defining your problem in relevant terms. And conversely, tell them what you're doing so they're not blindsided, so they can start to monitor your process. They can start to organize their own thinking, and then stay in touch all the way, because as you get into a process, inevitably there'll be surprises. If there weren't going to be surprises, you wouldn't need the process. So it's collaborative, two-way decision-making from the beginning, sort of defining the problem, which increases the chance that you will allow people to affect the options that you're then evaluating. So some other examples are Food and Drug Administration. If you search, with this title, you can find it online, has been implementing for the last few years a strategic plan for risk communication that tries to implement this kind of process. One expression of it is to develop policy on a variety of issues. These were recommendations from the Risk Communication Advisory Committee from a few years ago, which talks about how to manage emerging events. So imagine you're getting reports from the field that maybe a medical device isn't working so well. When do you start to tell people about it? If you tell people on bad information, you may alarm them unnecessarily. If you wait too long, then you may allow unnecessary harm and then be guilty of a cover-up. So we offered some recommendations for FDA across its regulated regulatory areas. Another thing that FDA has been doing is a national consultation. Once every quarter, they take a difficult medical area and have a day-long hearing. These are all they're webcast. You can find them archived online, trying to hear from patient advocates, but also patients themselves who are concerned about the development and approval of drugs. Here's for chronic fatigue syndrome. They've done sickle cell disease and others. FDA has also tried to be more transparent about the basis for its decisions to approve drugs. It doesn't announce its base. When it doesn't approve a drug, it doesn't say anything. But when it does, it is now, as of this year, will be reporting its conclusions in this standard format, which I helped some with its development. The behavioral principles that guide it are basically the same behavioral principles as guided the development of the drug fact box. The one thing that's different is that, and again, all this you can find online, is that it makes a distinction between evidence on the left-hand side, and regulatory regulatory judgments on the other side, because FDA can't just give the fact. It has to make a decision, always reflects some sort of trade-off. So it tries to give its rationale, and it wants to make clear that it distinguishes scientific judgment from ethical regulatory judgment. So we have a fair amount of science on how to design the content and the process. What are the threats to effective communication? I think there are two. One is weak science, and the second is weak organization. So weak science. So this FDR, or Evidence-Based User's Guide for FDA, has a chapter at the beginning about the importance of using science as the basis for developing for prototyping your communication, and the need for empirical evaluation because you can never get it right. Every chapter ends with guidance on how to evaluate your communications for no money at all, so there's no excuse not to do it, for a little bit of money, or for money that is commensurate with the personal, organizational, and political stakes that are resting on effective communication. But if you did an environmental scan, you would find that most communications about most topics in most areas, even when are not subject to any evaluation at all. So why is that? So why isn't everything evaluated? As a psychologist, my assumption is that everybody has faulty intuitions about how well they understand other people and vice versa. As a result, they may communicate poorly because they think they understand their audience, think their audience understands them, and then blame their audience because it looks natural. What you're saying makes sense to you. Psychology's, particularly social psychology's, perhaps strongest stock in trade are corollaries on this general phenomenon. We have the common knowledge effect, the false consensus effect, and so on. So the common knowledge effect is we exaggerate how much people share other people share our knowledge. As a result, we fail to provide them with critical information. And we force them to read between our lines, and if they don't share our background, they're likely to read differently, and either we don't make sense or they reach the wrong conclusion and then think that we misled them. So there's false consensus effect, there's a fundamental attribution error. We've got a lot of them. They're basically the same phenomena with different different labels, and these are more robust results than some of the psychological results that we've read recently often failed to replicate. So what's the antidote? Require empirical evaluation of all communications, trusting no one's intuitions. Second threat to effective communication is weak organization, and without organization you don't get that kind of the evaluation that's essential to any sort of responsible communication. What does organization require? It requires proper staffing, strong leadership, and then proper organization. So staffing, in order to follow this scheme for developing communications, you need domain specialists, so people who really know about medical devices or pharmaceuticals or social policies, so that you get the facts right, and some people know what are the issues that end up becoming important to people. You need decision analysts, that is, people who will extract from all the things that would be nice to know, and which, as we as scientists are happy to tell people, what are the very few things that people actually need to know in order to make effective decisions. You need behavioral scientists to provide a certain kind of structure and interpretive ability in terms of finding out what it is that's important to people and what they know already, as well as developing communications that have some chance of success and will do a professional job of communicating. And finally, you need the people who are professional at communications, who will do the kind of environmental scanning, will check with the politicians, will find out what's legal, will set up the hearings, will make meetings like this happen. If you don't have all of these people, then the job won't get done. And you also need leadership to make certain that they're staying within their proper roles. So, and and everyone is a stylist. So if you're trying to develop a communication and you let a doctor or a physicist or whatever have the last edit on the communication, they're going to put in things that look right to them, even if they don't look right to the audience. There are communities like climate scientists and nuclear engineers who have been messing up their communications for years because they insist on, the technical experts insist on having the last word and not listening to the evidence on what the people they want to reach actually hear. So to keep people in line, to get the resources needed, management must see communication as strategic, not an afterthought. They must assume stewardship over the process. There are many organizations in which the communication person is somebody with, as we say in the U.S., somebody with a bachelor's degree in English, is low status, given the job to at the end, whereas it's, where the fate of your public or the fate of your organization depends on whether the process is respectful and the content is effective. You need to view this as something important. On a press for industry-wide discipline, your agency, your firm can do it right, but if your competitors or your allies do it wrong, they can undermine your work. And finally, you need to separate what's now called public affairs, used to be called public relations. So every organization's need to toot its own horn to make the case to promote itself, need to separate that function from that of public health, of ensuring that people get the information that they need. And then finally, you need some kind of an organizational structure that will keep all of this together. So I was particularly interested in this meeting because of the various national experiences here, beginning in Sweden and French. Each of us gives us an experiment that works in a particular setting where we might learn from one another. I thought I'd conclude with a few other examples. So I think FDA has another model that might have elements that would be suited for some places. FDA is developing what some economists call absorptive capacity. That is, trying to cultivate staff that will know when they've got a communication issue, be able to do some things on their own, and know when they need need help, and can follow the literature. If you have nobody on staff who knows anything about communication, just like about anything else, you're going to be sold something that doesn't work by consultants. I mean, somebody will sell into whatever market you have. If you don't have knowledge internally, then they're going to be gullible. There's another model. I think the universities are often not a part of the solution here. Within the social sciences, we're often quite we fight over the definition of problems. We don't get along. We don't work together. Kind of sole proprietorships. Half of my department is in engineering. Engineers have their own issues. Engineers are accustomed to working together, not to thinking that there's any silver bullet for doing for communication or anything else. They want people who have deep expertise in some area, know their field generally, and will be able to get together to build a bridge or whatever. So university departments that have a foot in the real world where people work together are actually fairly hard to find. I'm proud to be in one of them. Here's another model at a national level. The Medical Research Council used to have an applied psychology unit that I was fortunate to spend a year at. All of the staff members there were judged by by their ability to publish in top disciplinary journals and their ability to provide benefit to society. So it wasn't a place for people who couldn't do it. It wasn't a place for people who couldn't do the science and let them do the applications. It was led by some of the. For those who are the psychologists will recognize some of these names, some of the best cognitive and experimental psychologist of their era. Sadly, for me at least, it has become a brain unit rather than this unique beast. It's a great brain unit, but we have lots of great brain units. We have very few places where you have this kind of commitment to strong science and public service. Alan Baddeley, who was the head at that time, as well-known cognitive neuroscientist, had, I think, an excellent conceptualization where he thought this collaboration, this having a foot in the real world and in the academic world, was essential not only for science here, psychology, providing service to the society that supports it, but also for the health of psychology. And he said the distinction between applied and basic science or psychology is an artificial and a misleading one. It suggests that you go from the lab to the field. He said the health the health of the world and the lab depends on these two bridging activities. One is he called applied basic science, which is taking what you believe to be true in basic research and seeing how well it holds up in applications. And the second was basic applied science, which is pursuing fundamental topics arising in applied contexts. And if you look, one can look at the history of psychology and probably many other disciplines, operations research, for example, and see how something like a national war effort, some sort of commitment, pulled people together. So my conclusion, any field, medicine, nuclear power, depends on a commons of public goodwill that grows or shrinks each time that the field comes to the public's attention, and the science of communication can help ensure that the field gets a fair hearing, leading to fewer but better conflicts, and some references. Okay, thank you.
Thank you, Baruch. Questions? John?
I have to wait for the mic.
Okay.
I don't know why I didn't slide it. I wasn't clear how your analysis applies to a problem I grapple with all the time, and that is, one is often invited to consider the risks of a technology, of pharmaceutical or whatever it is, and however accurate the presentation of those risks are, they're very usually not presented alongside the risks of not introducing the technology or not making the pharmaceutical available to people. And how do you persuade people actually that they need to do both of those things, that it is never enough just to know the risks of doing something, you have to know the risks of not doing it. This is the problem with something that I think bedevils European science, and that is the precautionary principle, where you're invited to regard risks of introducing something new as much more important than the risks of not introducing that new thing.
Yeah. So I would say that one needs the kind of organization and leadership in order to get the issues, where it's possible to get the issues framed in an appropriate way. So both the two examples that I had, the drug fact box and FDA's benefit risk framework, both present the contrast so people know what kind of trade-off they're making. If the situation is out of control, you may not be able to do it, but it's a leadership and organization question. On the precautionary principle, I think that some of the advocacy of the precautionary principle is from people who feel compelled to be irrational in the sense that the analysis game is rigged in a way that they don't have equal standing. I mean, they don't have the staff that are capable of doing analyses, of doing the kind of critique of the things that the think tanks and the national labs and whatever ever produce. So attacking analysis may be the only way to get you voice, which then puts you in a position of being irrational in the narrow sense, but perhaps rational and strategic in the larger sense.
And yet in some of the classic cases, it's the other way around. I mean, very recently, I was mentioning this in my talk yesterday. The head of the NIH, Collins, was inviting people to be intimidated by the risks of MRT and failed to mention that the risks stood on both sides of the equation, because the patients who suffer from mitochondrial disease will go on having children, and the consequence of that is that they will pass on in the germline a known defect.
And so my take on I taught, so I wasn't able to get here in time for your talk. But my take is often that spokespeople have a very poor understanding of their audience, and they communicate badly, think that other people are idiots, and then end up presenting themselves in irrational ways. And maybe that was the case with somebody who's very distinguished in other areas, but not a great doesn't have great insight into public policy.
I will quote you on Francis Collins. Thank you.
Another question? I have one.
Yes.
I think you talk a lot about communicating facts, communicating strong and weak science. What we are doing in this group is communicating values. Mm-hmm. And I, for one, do not believe, I can't resist trying to tease John. I don't think that values has to do with beliefs, and that only part of the brain is truth tracking and a belief system. Mm-hmm. So is there a difference there that we have to think about how we communicate the values? Because we are doing both things in these committees. We are communicating today weak science because there are not much evidence sometimes, and we also have to communicate the values.
So actually I had, perhaps in thinking with this audience, I took out the word facts from some of the previous slides and put the word issues, and then tried to use facts and values in parallel. One can think of a kind of supply curve for facts, what's most important, next most important, next most important, for somebody who has a particular set of values. I think with the values, I think the way, or I guess we in my science think about it, is that there are that often we don't know what we want in novel situations, and that we construct our values, and the useful form of communications is to show alternative ways of looking at a problem that might not have occurred to me, so that I feel once I've made a decision and once I'm living with the decisions, I say, oh, I never thought about the regret. I never thought about how it would affect other people. So the science there is much more poorly developed, but that might be a conceptualization.
I think you had too much to drink yesterday. No questions. So you're tired. Johan.
Thank you for the talk. I think there's often a difference between different processes of communication, in that some are really processes. They take place over a long time, and you have the opportunity in a way to revisit the earlier parts of the communication and try to modify your communication in response to perhaps misperceptions. And I think, as I understood your talk, it was mainly about these long-term process of communication, but often communication, scientific communication, takes place in rather short meetings, and where there are sort of strong time constraints on the communication. And do you have any strategies for how to handle those kinds of communication, or is it sort of basically the same type of advice?
That's clean slides, sans serif font. As I said at the beginning, I think what we do, the people who study this, in a sense, formalize what's natural, is try to understand your audience and be as relevant as possible to them, and then collectively we have a set of skills where we can do a better job. So find the experts, do some analysis, and I would say in terms of the values, I think we don't talk to philosophers enough, because that's part of your expertise in looking at those alternative perspectives. And I think you'll often find people who, you know, we just done some work on Ebola. So we have a crisis. There's no time to prepare communications, and yet it's not that hard to do good communications and to do rapid prototyping, and so there's really no excuse, you know, not for being prepared and not for testing what you do.
Okay, I think you said something, final thing, a question or comment. Lotta said a few things. Lotta often, I think she must have read your papers, and she tells us in the committee to talk to the public, to have all type of decision groups to find out what the real questions are, what they are worried about. And being a philosopher, I don't trust that sort of groups. I want to think myself. And I think that's a good thing here, that we should do that far more, because it gives us a platform, a basis for what we are doing. The other thing Lotta also said yesterday, and that you seem to emphasize, is that you should start communicating at a very early stage. You should not wait until it's too late, and Lotta was emphasizing that yesterday. So there are data for that too, which seems very good.
Okay. I'm glad if I repeated it.
Good.
Okay.
Thank you very much, Baruch. Okay.
So good morning also from my side. Of course, for me, it's also a strong desire to align myself to the row of those who congratulated the Swedish Council for the excellent work you have done throughout the last 30 years, and we're looking forward for the next 30 years. And I guess this conference puts into a nutshell what you have done in excellent work. And our next speaker, the next opportunity to listen to a talk demonstrates that. And we all, I guess, are privileged now to listen to a talk to Baroness Honora O'Neill, one of the outstanding figures in philosophy, in bioethics, in the entire world, I would say. And we're looking forward as she deals with a topic which is of extreme challenge for our current days. And I guess we had a talk on that yesterday night. She will address that topic, not from a lawyer's perspective, but from a philosopher perspective. And I think it's very useful not only to look at the questions of data protection from a legal point of view, but also to assess and evaluate our own understanding of how useful and crucial data protection, self-determination with regard to data and data sovereignty is. Just if you remind the novel published 2 years ago of Dave Eggers with the 3 commitments of or confessions of the so-called circle community, that privacy is theft and that sharing is caring and secrets are lies. You know, that was a dystopian novel. But if you look at what's going on in social media in the field of Google, Apple, Amazon, and all the other data lords, I think we should be very much concerned about that question with regard to how we safeguard our autonomy. So we are very much looking forward to listening to Baroness Honora O'Neill, former professor in Cambridge and member of the House of Lords. So it's a pleasure, Honora.
Thank you. Well, good morning, everybody, and I'm very sorry I have not been able to be here for more of this conference. It sounds to have been fascinating, and it's my bad luck that the week only gave a narrow window. It may be your good luck or bad luck, I'm not sure, that having offered a couple of topics for this conference, I mistook which one I had agreed to. And so you're going to get a talk, a genuine talk, but it is a topic on which I feel reasonably confident to talk, in that I've been involved in many conversations, as well, of course, of writing on it in the last few years. And it is the, I think, very serious question of whether the data protection regime, as it has been and as it will be in Europe, is adequate to protect personal privacy. I feel that quite often one reads something in which people have settled the matter definitionally. They imagine that personal data, as defined, are private data. That's where I'm going to start, because I think that definitional equivalence is, in a way, part of the problem. Still, take yourself back 30 years, at the time of the drafting of the Data Protection Directive, which received national implementation in the various EU states. I think one would have thought, wouldn't it be a good thing to have a comprehensive way of handling data that secured a measure of privacy that was relevant to all domains, not just to medicine or to commerce, but everything. And one would have thought perhaps that given it was privacy one was protecting, the really good thing would be to find a governance mechanism that was highly individualistic, because we think of privacy as being individualistic. It is his privacy, her privacy, their privacy, whereas we may think that it is the confidentiality of, for example, institutional data that is an issue. So I can see the temptation of the data protection approach to privacy protection. I think it's a very great temptation, and it has not been resisted, as you all know. However, I hope to suggest to you that it's a temptation that we have very strong reason to resist, particularly if we care about privacy. So that's a rather polemical statement of why I'm going this route. So the focus in a data protection approach is first of all on defining what one's going to protect. And the answer is verbally obvious, simple: personal data. They're going to be protected. What are personal data? Well, there the problems start. On one view, personal data might be data that pertain to persons, the things that are true of individuals. For example, each of us had red blood cells, but that's not what we mean by personal data. That's true of every human being. That's not personal. Or it might be the people whom I can see in this room have hair. I can see it. You all know it. But that's not personal data. That's just something that we commonly observe. No, we think it's a subset of data that are true of persons, not just everything that's true of persons. But what subset? Very, very hard, in my belief, probably not feasible to answer that. Try the other tack. Try thinking about not data that are true of persons, facts about persons, but try thinking about data that people own. And that approach is quite often taken. Well, what data that I own, that might be my intellectual property. And I'm all for a bit of intellectual property law, and it's in a very great mess internationally and for the most part nationally. But that's not what personal data are about. They're not data that people own, although that mistake has been made, and many of you will know the book about Helen Lane, from whom a cell line was derived, and there may well have been breaches of her privacy, that it was called the HeLa cell line, Helen Lane, and that was probably a breach of privacy, but not because she owned her cell line. So it doesn't seem to be ownership, and it doesn't seem equally to be that data that are pertained. Well, at that point, let's go and look briefly at the solution that was arrived at for the Data Protection Directive all those years ago. And the definition is modal, and it gets much closer to what we're concerned about with privacy. The idea was that data would be private if, but only if, it is possible to identify the individual to whom they pertain using reasonably available methods. There's complexity to this, but I won't go into the complexity. Well, that sounds rather good initially, because it means that I did that in the first session. Now, some data, it then turns out, are going to have to be personal in one context, but non-personal in another. Because what can reasonably lead to the identification of a person depends on the other information available. Over the last few years, we have seen more and more emphasis on a term which is not quite an accurate term, but I see why it was adopted, the term inferential disclosure, where one discovers the identity of a person, not because one is told whose medical data it is, but by inference. Now, I do not think we can expect there to be a system in which there is no inferential disclosure. When you first read a detective story, probably when you were 10 or 12 years old, it was rather a pleasure to work out from the clues who done it. And that is inferential disclosure. It is using inference rather than disclosure. That's why I think the phrase is a bit of a nonsense, inferential disclosure. Inferential disclosure is meant to be finding something out by inference. We do it all the time. We depend wholly on it. And that's the whole problem. You can't block it. You can't say, oh, you're not allowed to infer anything from what you know. Now, inferential disclosure has become a great deal more feasible in more contexts with the development of data linking and data mining technologies in the last 20 years. It means that on some occasions it is possible to identify the individual to whom data pertain using a variety of databases that are in the public domain, but that put together provide the clues, not to identify everybody who is in the data set, but to identify enough of them. And we can see this all around us. It is extraordinarily powerful, extraordinarily widespread, highly commercially valuable, highly valuable to the security services, and absolutely ubiquitous. There we are. What are we going to do in the age of data mining to protect privacy? That, I think, is the new question. Well, I think there has been an answer for some time, and the answer has been we use the governance mechanism in a more intense, penetrating and effective way. The governance mechanism in data protection is above all the consent of the individual. We try to make that more rigorous, more robust. We saw some move in that direction, I think, some decades ago, as we had the successive iterations of the World Medical Association's document, the so-called Declaration of Helsinki, where they started talking, and it's now very widespread, about more specific and explicit consent. So specific and explicit consent. If you make the governance mechanism more demanding, then surely it will work even in the era of data linkage. That's a thought. And that is indeed the thought that has animated quite a lot of the discussions in Brussels about the new data protection regulation. I'm sure this audience knows a lot about that regulation, which is why I decided to talk about the background and not the regulation. But I think it is significant that there has been such contention and dissent about the draft regulation that several years out it is not yet complete, that it is said that it will be completed under the Portuguese presidency. We shall wait and see. I'll come back to some of the changes that will have been agreed by then, or it is said will remain agreed. I'm not quite certain. But there we are. The attempt is to make it more exacting by requiring not just consent, but specific and explicit consent. Here's a problem. Consent is what in my trade we call a propositional attitude. You can always make it more specific, more specific, more specific. You can put more and more and more detail in. You can also make the process of consenting more and more explicit. That is to say, you can not merely have a few mumbled words in the doctor's office, you can have an exchange of documents, you can have a subsequent conversation, you can have witness statements, and there are perhaps some areas of medicine where this is a good approach. I remember a colleague in Cambridge, I was chairing the Tissue Bank Management Committee, he was an oncologist, and he had a very beautiful, very elaborate consent procedure for women with breast cancer before they went to surgery. You couldn't fault it in one way, but what you had to note was that breast cancer is quite unusual. It tends to affect women in middle life, in what John Stuart Mill called the maturity of their faculties. It is a serious but not an urgent matter on the whole. Serious means you can spend resource. Urgent means you don't have to get consent immediately now. So you could do this lengthy process that took, at the minimum, 2 weeks to go through, at several conversations, conversation with surgeon, conversation with nurses, conversation with counsellor, documents all the way. It was, in one way, beautiful, but we also know probably irrelevant in an incredibly high proportion of medical cases, where we have also always to remember that a very high proportion concern people who are not in, let's call it, not competent to consent, to be blunt. They are children, they are infants, they may have dementia, they may be unconscious. The proportion of medical episodes where one of these is in the case is, of course, much higher than we like to imagine, because that's where illness and intervention happen a lot, when we have old, frail, confused, or unconscious. So upping the standards for consent was always going to be a very difficult and possibly an unsuccessful strategy, except for a few special contexts. Interestingly, the discussions in Brussels about the new data protection regulation initially went this route. In fact, for most of the period when it's been under discussion, they've gone this route. Let's make the consenting more difficult, more demanding, more exacting, ethically superior. Let's make it explicit and specific. And at one stage, this looked highly threatening to a great deal of medical research in Europe, where, after all, whether we're thinking about epidemiology or public health research and many other things, the reuse of data to which to whose holding some consent has already been given is fundamental. So the idea then emerged, and this was the case, I would say, about this time last year, when the claim was that what we want is specific and explicit consent to each lawful new use of any lawfully held data to whose reuse broad consent has already been given. Well, you can see what that would do, and as we happen in the UK to have a number of longitudinal studies of, we think, of great value, including Biobank UK and the Scottish Health Informatics Project, but also a great number of cohort studies, we were, of course, very concerned. I sit on the Medical Research Council, and we spent, together with the Wellcome Trust, who have been leading on this, a great deal of time dealing with this, and making links with other European research funders, other European academies, and I think there was a broad consensus that this was an impossible barrier to future research. So, what's the simple way to deal with that? Well, it's called a research exemption. So you exempt research. You say, all of this applies, but not to research. I think that's where we are, and I don't think it's a very happy place to be, because what counts as research? Do we count, for example, market research as research? Maybe that's opening the door too wide. Or do we count all sorts of research as exempt? And in any case, even if they are exempt from this specific and explicit criterion, what about the basic data protection principles, which I argued were, in any case, unsatisfactory? Not a happy place, therefore. We don't know what will happen, but I think one of the things that we do too little when we're talking about bioethics is to remember that the data protection regime wasn't devised for medicine or research, or research in the biomedical sciences. It was devised for all institutions that retain what are seen as personal data. Now you might think, okay, everybody has to give a little bit on this, and if it's doing terrific things for those parts of the of life in which data are collected for non-scientific and non-medical purposes, isn't that worth it then, that data protection works, for example, for commerce, where huge amounts of data that would enable you to re-identify persons, remember that modal criterion, are collected and retained? And the answer is, there was simply a dual standard. The standards used for consenting in outside biomedicine are very much lower. Do you know when you download new software and you tick and you click and you get it? Well, probably you've been inquisitive enough to look sometimes at what you're actually doing when you tick and click. And, of course, you are agreeing to what's usually called a EULA, an end-user licensing agreement. In the EULA, you will find 45 pages of dense legal prose. Those are the terms and conditions. Sometimes it just says, terms and conditions apply, and you're agreeing to those. And the amusing thing is that our legal systems regard the fact that one has agreed on this basis of no understanding and probably absolutely no knowledge of what the terms and conditions are, it's regarded as quite adequate. I'll come to the caveat on that. But I believe we do well to think much more about the commercial use of data protection and the fact that actually we've got a dual standard. One standard which is extremely demanding and aspirational for biomedicine, and another standard which is extraordinarily undemanding in commerce. And in fact, commerce finds it so undemanding that it's not adequate. What really protects you when you're buying your new software or whatever else you're buying is consumer protection legislation, not the terms and conditions up to which you signed. There was a rather nice attempt recently to show how nonsensical this was when a group of people produced some terms and conditions that incorporated a Herod clause. The Herod clause said, "And I give my firstborn child to be killed." Most people signed up to this. And it just tells you how absurd it is to rely on tick and click as amounting to consent. Well, if not tick and click, then what? I think we can see the commercial world turning a corner at the moment. Consider the so-called mis-selling scandals of the banking crisis of 2008. What is being said repeatedly is that the products that were being offered in forms where the punter, the purchaser, could not hope to understand what the product was. Consequently, it was mis-selling. It was failure to communicate what was relevant to those products. And I have to say the number of people who actually understand that all of these products appears to be rather small. A great number of the employees of the institutions that sold these products did not, it turns out, understand the products, did not understand their risks for others. And that, I believe, should suggest that possibly this whole edifice where we think there's something called personal data, and then we have a governance mechanism which is called consent, and this governance mechanism prevents the misuse of personal data, is going to be revealed as a historic folly. But we live with it. And I say all of this taking the right to privacy rather seriously, but I do not believe that the data protection approach takes it sufficiently seriously. Let me, before I shut up, give you one final comment on consent. How did consent come to be such a dominant feature of the intellectual landscape in medicine and in bioethics and in research ethics? Many people will say, well, if you go back to the Nuremberg trials in the late 40s, we see that consent is introduced there. If you actually read the way in which it is not introduced as a fundamental ethical standard, because it is not a fundamental ethical standard. It is introduced in context as a way of respecting some fundamental or operationalizing some fundamental standards for preventing coercion, duress, deceit, and overreaching similar very serious ethical failings. That was, after all, the context of the trials of the Nazi doctors, that they had not had the consent of their subjects, and clear enough, but they had coerced, they had murdered, they had mutilated, they had done these terrible things, and one way of operationalizing a process that would say no at that stage would be to say you get the consent of the subject. We all know they could never have got the consent of the subjects to those abuses. And I think it's entirely clear why in that famous memorandum and in the Nuremberg, the emphasis is on the power of consent. But it was not because consent was thought of as in and of itself proof of something. And indeed, all the things that we now know about adequate communication and the way in which communication can be spurious show us why consent can be spurious. Roger Brownsword introduced a very nice phrase into these debates, which I've used often enough and will use again, consent fetishism. There is a lot of consent fetishism about, and I think that we need to do better. So I'm going to spend just a few minutes discussing what direction we would need to go to do better. The one thing I'm not going to discuss is what can we do about the European directive, about its national implementations, or about the European regulation, which, if agreed, is going to apply uniformly across all states. What can we do? Well, we know what we want, don't we? We want ethically robust data governance. It's a bit of a mouthful, but it's easy to see that that's what we want. And let us concede, there might be contexts in which consent procedures were an element in ethically robust data governance systems. But fundamentally, if you're going to have ethically robust data governance, you need to have a number of things under control. First of all, you need to have some control over who may have access. In medical research, we tend to say, well, bona fide researchers with the relevant qualifications. And you need to have some control over what they may do with the data to which they have access. For example, they may analyze the data, but they may not disclose the data with identifiers. I mean, we talk about identifiers for what it's worth. We all know that now data mining has made the very notion of an identifier less secure. Then we need some control over to whom may they communicate the data to which they are privy. And when may they communicate, and when must they communicate? These are the elements of ethically robust data governance. They aren't pushing it over to individual consent. If this begins to sound really rather like that more old-fashioned notion, confidentiality, that's because it is more like that. Now, what was wrong about confidentiality? Why did people think, oh no, confidentiality is not enough? And I think that that's a chapter on which we ought to look more, but it seems to me that many people said, well, look, confidentiality, it's just too fragmented. There's professional confidentiality, lawyers and doctors. There's commercial confidentiality in companies. But confidentiality is not sufficiently general to protect the right to privacy. I think that was true. It wasn't sufficiently general, but that we might have done better to build up the system of confidentiality, because the real issue in this, in protecting people's privacy, their informational privacy, is to have a point of control, an ethically robust system of governing the use of information. And I very much doubt that we're going to get there either with the current system of the data protection directive or its national implementations, or with the direction things are going with the data protection regulation. Thank you.
Yeah, thank you so much for this clear, sophisticated diagnosis why the given regime of data protection is not sufficient to protect persons and the privacy of persons, and criteria for an ethically robust alternative. So I guess that was thought-provoking and stimulating both, and I invite you all to comment and raise questions. So I see the hands raised. The lady was first.
So,
no,
hello,
the lady.
One
row above you. The lady was first. Ladies first. So.
You mentioned the double standards regarding research and the commons and regarding informed consent, and I can only agree with that with all my heart. And another example I can bring up is probably in today's society of the social media, whatever it's called, of course there is this double standard as well. Maybe I'm comparing apples and pears here. On the one hand we have research and We worry about that somebody is going to collect the data about my blood pressure or my temperature when I was in the hospital or something. And then, of course, there are also ethicists who argue whether that can be considered as personal data about me or it's just medical parameters, we should call it. On the other hand, people can put out their whole life on the Facebook. And of course, that's not the same as research, but probably someone can do research on that without me knowing about it, if there's thousands of people who can see a lot of things about me. So I don't know if that's a good example, but I think there are double standards in probably many other areas as well.
So may you introduce yourself, although I forgot it by myself?
Sorry, I am Christina Hug. I'm from the Department of Medical Ethics at Lund University.
Yeah. Thank you.
Thank you very much for reminding us about social media. It's very important. One thing people say cynically is that if you're getting the service for free, you are the product, because the social media make their money by selling your information. It is to advertisers and so on. So it is a good example of a case where the tick and click approach, as I call it, to giving consent is what there is. Now, we have privacy settings of various sorts as well, but people very often have little idea when they start using social media what further uses and reuses are going to be agreed to. And I find it fascinating that the assumption is that social media can sort of go ahead without having to get specific and explicit reuse to each new use of the data, because, of course, it couldn't work that way. Whereas, in biomedicine, because we're dealing with sensitive data, we should get specific and explicit consent for each lawful reuse of data, thereby undermining a great deal of medical research. So I think there are double standards. It is, and that's why I believe those of us who do bioethics should spend a lot more time thinking about the specificities of what is being counted as consent in other domains of life. People will say, oh, well, in biomedicine you're dealing with not just personal, but sensitive personal data. Yes, but they're dealing a lot with sensitive personal data on the other.
So no.
Right, so sorry about that. A few observations, I think. So one thing that seems to be that I totally agree with you that the consent mechanism is a means to an end and not the end, right? And it seems the consent is also based that you describe something that people are supposed to consent to. And so in the research setting, I would say that there's one important thing that happened that you described, that you cannot, in broad areas now of research, especially genetic research, you have to stop to promise anonymity as being guaranteed. And you have to be open about that. And you have to invent something else to say, which is simple enough, but it is still true with the situation such as it is. And I think that, and then you can sort of keep to the old ways of doing it. And I think that I'm not sure that you will lose a lot of people sort of joining up to research because of that alone. The other thing that you point to, I think it's more important, and this is the fact that in medical ethics and also in medical and research ethics regulation, we have sort of imported a solution which basically comes from business law, which is the signing of a contract. And once you sign a contract, legal accountability is transported to you. So the other person who sort of gave you the contract or signed can say, it's not my fault. It's the other person's fault who signed the contract. And that's basically what this mechanism is doing when it's put inside regulatory systems. And that also goes, so one could question the sort of rationale why so many people want to have the consent mechanism. I sometimes suspects, being an ethicist, that rationale has very little to do with ethics and more about having a nice mechanism to wash your hands.
I'm sure you are right that the appeal of the relying on the consent mechanism for data governance in biomedicine has a lot to do with the very same things that are appealing in the commercial sector. That is to say that you lay off liability. Oh, but I had consent to that. And that's true up to a point, but if you move into this terrain where people are thinking about specific consent and explicit consenting for each lawful reuse of data that is already lawfully held, you are actually into the domain where if you take it seriously, you stop research. And take as an example, I think an example is useful here. Biobank UK, 500,000 volunteers, I'm one, have given the bank access not only to a sample, which of course permits genetic analysis, and but medical history and continuing access to their health records. The researchers, and this is what makes it an ethically robust data governance system, have to request access to a very specific set of data. For example, 500 people who came down with liver cancer since they entered the study. And then it might be possible to see, did these people have a certain genetic features or dietary features in common. That's the idea. But that works because it is a much more robust mechanism, but it would not work if you had to go back to the data subject with each request, saying, would you please permit this research study to be done using data which you supplied 7 or 8 years ago, and if you did that, you would destroy the statistical integrity of the samples because you would get different non-responders in each iteration of requests. I mean, you know, if you get too many requests, you miss some of them, even with goodwill. So it would simply undermine the whole objective.
John. Honora, thank you for a wonderful talk. A couple of sort of footnotes to it. One thing I think that exercises me is two facts. One is that, sorry, I can't talk across that. Nothing digitized can be kept private. So that anything that is in digital form can be hacked if you have the competence. And your genome is very easy to access, not necessarily because it's on record somewhere, but because you leave genetic samples all over the place, and somebody who is interested in your genome can follow you around, take your drinking glass or whatever it happens to be and run your genome. And both of these points came up. I served on 2 government advisory bodies in the UK on genetics. And one of the things I suggested, and I would be interested in your comments on it, is try a different tack with privacy and confidentiality and security of data. Don't try to keep it secure, because that, in a way, that's a lost cause. And it's misleading, I think, to promise people that you can keep medical records that are digitized secure, because nobody can. So try to identify, have a new approach. I'd try to identify wrongful use of data and criminalize it to hell. Criminalize it to such an extent that if a rich press mogul wants to publish your details in his newspaper, the financial penalties for trying to do that will be so great, including also imprisonment and so forth, that they will be deterred. One piece of very good advice that I've heard on a number of occasions about keeping your data secure is be boring. If you're boring, nobody is, and most of us are boring from this perspective. Once you become interesting, once you're a celebrity or once you're important in some sense, and somebody has a motive for getting your data, then it's a lost cause in terms of keeping it private and confidential. All you can hope to do is criminalize the use.
I would regard an appropriate set of sanctions as part of an ethically robust data governance system. the sanctions are rather complicated, I think, to think out, and there might, at the limits, be the use of criminal sanctions, including imprisonment, but I suspect the more usual sanctions would include things like denial of service on popular social media, or other sanctions of that type, and of course the informal sanctions of social life. Because I think that the lurid example you have of the wealthy person who, or perhaps you're thinking of a media mogul who wishes to access a sample from some celeb and get a genetic analysis, that's probably not going to be either the most routine or the most distressing sort of case. Yeah, you need to guard against those cases too, but the more ordinary cases that we need to guard against. So I'm certainly with you on sanctions. And I think we should spend much more of our ingenuity thinking about horses and courses and what are our appropriate sanctions. I think we have done some thinking about the research community where failure to keep to the terms of data access can, for example, lead to denial of future data access or future research grants. It seems to me that that sort of sanction, which is subcriminal, is probably quite effective. I've been part of a small group that the Wellcome Trust have in the last couple of years. It has a rather silly name. It's called YEGDA, which is Expert Advisory Group on Data Access, and it's quite heavily weighted to people with more technological savvy than I have. But it's striking how many little sanctions people are aware of or could be constructed. I don't believe it's beyond the wit of men and women to construct an ethically robust data governance system. It's just that we have to face the fact that people have fantasized that they're going to get there by the data protection route, where you can't distinguish which are the personal data, where you then don't know how the data governance ought to work. I think we need to go a new route. What I don't have any view of, and your question made me think of this, we have a reasonable expectation that an enhanced data protection regime with a research exemption for what it's worth will be agreed. So then we are ever deeper mired, stuck in the data protection approach in Europe, which it's not merely that it's very burdensome, it's also that it's not a particularly effective way of protecting personal privacy. So I think we really need to think again, and I agree with you that one of the lines we need to think of, part of ethically robust data governance, is going to be sanctions.
Sure.
So at the risk of straying into consent fetishism, I want to agree with something Christer said, but take it in a different direction. So we're agreed that consent is about operationalizing respect for persons, about giving people an opportunity to exercise autonomy. And if that's the base, I have no difficulty if we have a discussion where we say, well, consent, and I absolutely accept all of your points, consent, possibly as it's currently constructed, doesn't do the job we want it to do, etc. But then we at least need to be honest about this narrative and this dialogue, because in fact what we're straying into, if we do away with consent or find some other mechanism, and I find it interesting when you talk about a research exemption, or when you use the UK Biobank example, where I give my consent for ongoing, etc., etc. What we're actually moving into is an era where research is no longer supererogatory. It's in fact becoming a moral obligation. And if that's the case, and if that's what society deems to be appropriate, then that's fine. But let's at least have that discussion, because that's actually where we're moving, but we don't ever discuss it in that context. We say, oh, consent is faulty, and you're absolutely right, it is. And you're absolutely right about two different standards for commercial and biomedical. I accept all of that. But actually, there's a deeper issue at the heart of this, which is about what consent was there to do in the first place. So either we still believe that that's valid, or in fact we don't. But then let's have that discussion instead of saying, well, you know, because my experience of research is that when researchers want to access information that's important for their own studies, they have no difficulty going back to individuals. But when it's they have to get consent because it's some obstacle that's been placed in their path by a research ethics committee, then you get all the argumentation about how this is a barrier to research, it's really problematic. And as we know in the UK scenario, there have been discussions around dynamic consent, not where it's the obligation of the biobank necessarily to go back to the individual, but where the individual themselves at least retain some control by being informed about what their information is being used for and can therefore opt in and opt out. So I think we need to at least be honest about the conversation we're having. And if research is now a moral obligation, we can discuss that, but I would like to know that. Just a comment.
Well, in fact, a set of comments are interesting, and I agree with some of them and not with others, and I'm not going to be able to pick them all out. Is consent a way of operationalizing respect for persons? It's a way, but it's a very minor way if you think about the real panoply of mechanisms that we have. We have, for example, the criminal law that penalizes many forms of violence, coercion, and deception. These are the fundamental ways in our society of operationalizing respect for persons. Consent is a very specialized way of operationalizing respect for persons. It's one that probably has its so to speak, best exemplars when you have something like a relationship between equals and you have all those conditions for parity of information on both parties and so on. But I think we would make a great mistake if we imagined consent was the way of operationalizing respect for persons. And in a sense, I'm not against using consent where it can be a plausible way of setting a standard. But I believe that the fetishizing of which I spoke of, or which Roger introduced the terminology, the fetishizing is the fancy that consent can be the omnipurpose way of operationalizing respect for persons. And where we have, as several people pointed to, highly complex information that the data subject cannot be aware of and cannot control. There's a certain mockery in leaning too much on the consent criterion. And that's why I would argue we need ethically robust data governance. It didn't get all your points, but I think it got one set of issues.
So, it's on you.
Thank you very much for an interesting.
It's difficult for those in the back to. Yeah, I think there's a problem with the micro, or you should put it closer to your mouth. There's an alternative micro.
Thank you. Well, using the Facebook model as a standard for every informated consent. And one of the reasons is that you talk and other people here talk about the double standards as a problem, but is that really a problem? Doesn't it reflect the double or triple standards that are within us? that we judge the value of our consent and the value of our information in different ways, in different contexts, depending if we're on Facebook or if we are in a hospital. And it was mentioned here that might not be the best idea just to scrap the consent. If we're stuck with consent, and we're going to be stuck with consent probably in some ways, isn't it more efficient than to talk about smarter ways of getting consent, of mobile consent, sticky policies, developing technical standards for making it more practical, more plausible to get the consent of research persons or whatever? Thank you.
Thank you. Yes, I think the route of seeing whether we can make consent more genuine, more effective, is a very important route. And of course, there has been a lot of what one might call micro work on the consenting for particular purposes or in particular contexts or with particular sorts of procedures, and making things more comprehensible for people who may have various barriers to comprehension. I'm entirely for that. But nevertheless, I don't think that one should throw too much of the burden of permissibility on consent. It is what it is. It is a fragile and easily overburdened process of governance. And if I'm sort of one central message of what I'm saying is we better look at the other bits of data governance that make them ethically robust with equal care and attention. It doesn't mean that consent is always useless, and clearly the data protection regulation is going to preserve some notion of broad consent in there. But I have to say, I think broad consent can't just be a matter of ticking a box. It has to be based on some measure of comprehension. That's why in biomedicine and elsewhere we use the phrase informed consent. The phrase is pretty aspirational because often one has to say it is very selectively informed consent that we're talking about, or very partially informed consent. I rather love the clause in the Declaration of Helsinki, by the way, in which the physician, they always muddle up the physician and the researcher in the declaration, the physician, after having ensured that the research participant has understood the content of the consent, after having ensured that the other party has understood, that's I understand the aspiration. It's thinking, well, the caveat emptor principle that rules in commerce is too weak. And I agree. But frankly, ensuring that other people understand something is not always a feasible objective. So we better not be putting too much weight on that sort of move. So I'm not for removing consent. I am for getting realistic about the fact that it is only worthwhile in the context of a broader range of data governance standards. And finally, when I hear that discussions in Brussels are in part focused on a supposed distinction between broad consent and blanket consent, I tend to get a bit worried. I'm afraid I have not had time to read about what makes it blanket rather than broad. Goodness knows. But these attempts to, remembering, consent's a propositional attitude. There's a proposition to which the person gives or refuses their consent. That proposition, mere matter of semantics, is always indeterminate in some respects. You could add in detail to make it more explicit, then you lose the comprehension of the data subject. How far do you go adding it in? What degree of specificity makes it broad, and what degree blanket or indeterminacy, if not specificity?
So looking at the watch, unfortunately, we are running out of time, so I have to have a break because we have a delay of 5 minutes still yet. So, but it is a token how stimulating your talk was that I had to set a break, and I had many fingers raised, and I guess many of us were curious about learning from you how to put into practice this alternative, ethically robust regime, because as far as I think your own evaluation of that, there will be also some shortcoming, as there are there's a lot of blurring of boundaries between commercial and research and other, and an exchange of data, which is extremely difficult to safeguard these communicating processes of data. But that will be the next talk in the perhaps 35th anniversary of the Swedish Council. So thank you so much for this stimulating talk.
I should say, thank you all. I will just add this. I do not imagine that the future, an adequate future, would be one regime. I think part of the failure of the data protection approach to protecting personal privacy is that it has sought to be a comprehensive regime. I think that robust, ethically robust data governance has to be more context-specific.
And now it is a pleasure for me to introduce Reidun Förde. I hope I pronounce it correctly. She is a medical doctor and professor of medical ethics at the University of Oslo. And it is a pleasure to have you, because you address a different topic which nevertheless is of major importance for the entire healthcare sector, and where especially the, let's say from my perspective, the Scandinavian ethics board or political advisory board set the standard worldwide in addressing the question of prioritizing healthcare. And you belong to the group who issued the first report on prioritizing healthcare in Norway, and give us now, or put us into picture about your thoughts you had and the given regime in your country. So looking forward, the floor is yours.
Yeah, thank you very much for this invitation. And first of all, congratulations on your anniversary. We don't have such a thing as a National Ethics Council in Norway. And it has been very interesting to be here and follow you. Secondly, thank you for 2 very stimulating talks this morning. I feel humble standing here after you 2 distinguished persons who even are fluent in your own language. Honora O'Neill has been one of my heroes for many years. So, as already said, I'll take you through the prioritizing history of Norway. It's a very complex issue. It's a very emotional issue. It's an issue in which several expert knowledges are required. Economics, philosophy, political science, medicine. And one of the problems, I'll reveal this secret already, one of the problems is communication. What is this all about? And to reach out with this communication for us that we want to reach. I've been in this issue for many, many years, and often, every now and then, I ask myself, what kind of masochism is this? Because it gets more and more complex the more you work with it. I was on the second priority commission, and the last one, and I was also a member of the first National Council for Priority Setting, which was a result of the second suggestion from the second Commission. I'll end up with presenting the last one. This is a picture of the health minister to the left there, and the chair of the commission, Ole Norheim, who is a medical doctor and an ethicist. He knows very much about, his science is on resource allocation. It's called Open and Fair, this publication. We started early. We don't have a national ethics council, but we started, I think we were the first in the world as a nation to start up with a public commission. It started in '85, chaired by the professor of theology, Inge Lønning. He also chaired the second one. And both these commissions suggested 3 criteria which should be examined together. The first one is the severity of the condition to be treated. And severity was defined as loss of life years, loss of functions without treatment, pain, etc. Then it was the effect of the intervention. And the second one, because at that time they started to talk about economics explicitly, there should be a reasonable relationship between costs and effect, whatever that is. Sounds nice. The first commission put greatest emphasis on the severity of the condition. Nobody criticized it. It was full of very nice thoughts, consistent and in every way a good piece of paper, but nothing happened. The second one said that we have to put more emphasis on the effect of the intervention, because you can spend all the money on severe conditions, and it doesn't help much if it doesn't work. So the second commission wanted to, we also summed up what had happened during those 10 years after this wonderful piece of paper had been written. And we found that things had happened gone in the exact opposite direction that was suggested. The fields that were suggested to get priority, like chronic illnesses, psychiatry, treatment for the people who couldn't speak for themselves, the old, ill people, habilitation and rehabilitation, had lagged behind the acute conditions. So there was clearly a need for us on the second commission to say we need to get closer to out there. So we suggested some things that did have some effect. The 3 criteria were built into laws. Right after the commission, we had a new law on patient and user rights, which gave a lot of rights to patients. Very nice, but it had some consequences for the resource allocation work. But it was built into the laws. The blue label drugs, which is the system where drugs are taken on a list and the state pays. But the drug companies, they have to prove that these drugs comply with the criteria. That has been one success history. I think it's consistent and nice work now. And then there was a National Council for Quality and Priority Setting in Healthcare. I was on the first one, consisting of nice people with nice thoughts and no power. And everything, we did some nice work, I believe, but which the politicians didn't follow up and the clinicians didn't follow up. So they created a new council consisting of people with power. And I think they have had more influence, which is good. Then the most important work was suggested also by the Commission It took 10 years before the health authorities started the work, because it's a lot of work and it costs a lot, but they by means also of the Norwegian Medical Association, they challenged a lot of different specialist fields to tighten in their own house, to based on these 3 criteria, to make resource allocation lists on both on intervention and treatment. And these are used today. One problem is that they are not used in the same way from hospital to hospital, but they are used, and I think that was an improvement. And one thing, which I'll come back to in the end, is that I think the discussion after this commission, the public discussion, made prioritization more accepted among healthcare personnel and in the population. True, not true, but a little more, I think. Still, it's not well enough accepted. But a big proportion of the Norwegian population agree that, of course, there has to be some line between what should be done first and what can wait. I participated in a study by Samia Hurst, who compared 4 countries, Norway, Switzerland, Italy, and United Kingdom, and attitudes among general doctors. And Norwegian doctors, to the greatest extent, said explicitly that they did accept to take part of resource allocation work and to let some people wait and stuff like that. You can read that if you want to. I said that we also had a great assistance from the Norwegian Medical Association. Already in 1994, we made a new paragraph in the ethical guidelines, where you see that it's said that the doctor shall, in his and her practice, have due regard for the national economy. I have presented this abroad among colleagues from other countries, and they are very scared. They used to be that a medical association could write such a thing. Unnecessary and excessively costly methods must not be employed. A doctor must contribute to the distribution of medical resources in accordance with generally accepted ethical norms. Still, they don't do, I think. I'll come back to that. A doctor must in no way seek to provide individual patients or groups with unjustified advantages, whether financial, in respect to priorities or otherwise. And then comes the last sentence, which is being referred to. A doctor must give notice of insufficient resources in his or her area of responsibility. That is done all the time. Yeah. So there was little noise also after the second commission. And I think one reason for that was that the criteria, they were not specified. They were leaving room for interpretation, which is good in a way, because it leaves room for the clinician to treat each patient individually. But then comes the fairness issue in. So what is severity? Is it here and now? Does it include the past suffering and future suffering? Severity for whom? For the family? For children of a sick person? For society? And what about chronic illnesses? How can they be interpreted in this criterion? And patient organizations have criticized exactly this criterion for that. But they were uncontroversial. So, the overview of before the last commission was appointed. In spite of all good efforts, we have a problem with overdiagnosis and overtreatment, and the first distinguished speaker today mentioned this. It's an international trend now that we have started to speak about the problem of overdiagnosis and overtreatment. And Norway is a rich country. People are willing to pay, and it's in a way a saying that if you do a lot, then you're a good doctor, and if you do less, then you're not a good doctor. That's what people believe. It's increasingly difficult to setting limits. I work with clinical ethics out in healthcare, in specialist healthcare, and we see all the time that setting limits is very difficult. And clinicians, when I talk about priority setting, they say, well, give us backing, because we don't dare to set limits. New expensive drugs come up all the time. You all know about that problem. And I think this ipilimumab, you know that drug? Yeah. That was a big hustle in Norwegian media, and strong patients were fronting this very unfair situation that the health minister denied them future life because they didn't get this new drug. Very expensive. And I think that was the very reason why the health minister appointed a new commission, because something had to be done, obviously, and then you appoint a commission. The conclusion when we started our work was that we need to do some, so that resource allocation comes closer to the bedside. And our new criteria needed. This is a picture, just to keep you awake. The mandate for the third commission was to set a goal for the work, to look at the old criteria and to see whether we needed new ones, look at the processes for resource allocation, and suggest some instruments to get closer to reality. The process is pretty much influenced by Daniels and Sabin, setting limits fairly, which very many of you know. But user participation involves the public, and openness around what is going on, accountability. That's important. You already saw that justice is a very important value for the last commission. The greatest number of healthy life years for all, fairly distributed. Here are two guys that have been important, Rawls and Parfit, absolute priority to the worst off group. Yeah. So, we didn't exactly suggest 3 new criteria, but we tried to elaborate the old ones. And the old effect criterion was baptized the health benefit criterion, which does make sense in the clinic. You have to ask yourself, does this make a difference for this patient, health-wise? The priority of an intervention increases with the expected health benefit and other welfare gains. So it's not only what you can count. Even dignity at the end of life is to be regarded as an important benefit. Then there is the resource criterion. Cost-effectiveness criterion was never used. Now we baptized it the resource criterion, and what is important here is that we're talking about alternative use of resources. When something new comes in, you have to figure out what should be taken out. There's always an alternative use of resources. And also, we emphasized that resources, that's not only money. It's intensive care beds, and above all, it's knowledge. And we see that as a problem in Norway, where many people are so rich so they can avoid to get old. Very many of the plastic surgeons are out fixing, like the lady you saw there on my quick slide, and too few are back to really do the important jobs. So that's one example that specialist knowledge and it's part of the resource issue. And then finally, the health loss criterion. The priority of an intervention, here comes the dirty business, people. The priority of an intervention increases with the expected lifetime health loss of the beneficiary. And that has been very controversial. But the definition is healthy life years lost compared to a long and healthy life if provided standard treatment. It identifies the worst off in a way that can be quantified, and it gives priority to suffering starting early in life, given health gain of the intervention and acceptable use of resources. So, here is a picture. Using data from NICE in the United Kingdom, we have illustrated this by dividing several conditions into 3 groups. And the ones with the greatest health loss should, according to the Commission, be offered treatment which is more expensive than the ones with smaller health loss. Cystic fibrosis is one example. Severe suffering, many of them early in life, and many of them die at the age of around 40. So they miss a lot of healthy life. Yeah, this criterion, after the publication was launched, we were accused of being unethical, and also from the Norwegian Medical Association. I've been working there for 10 years, saying that we were cynical, we did not prioritize old people, and stuff like that. And one reason, I think, is that we have been talking about communication this morning. I don't think we get the Nobel Literature Prize for what we have been writing. We have not communicated well enough that this criteria, health loss criterion, it must be interpreted differently on the different levels. So on the level of the administrator and the politicians, they need figures. But by the bedside, the first question is, does it benefit the patient? What do we know about that? Does it cost, the costs are reasonable? And is it a substantial health gain? And this health loss criterion comes particularly into focus when there are extremely expensive treatment and there's shortage like organ transplantation. Already, people in Norway are not offered lungs because we have a great shortage of lungs after they have reached 65. But you don't get it. So, and it has been accepted so far. But I'll take you further on this health loss criterion. This is just a picture of variations in interventions done in Norway. We started to count, and we found that for almost all types of interventions, there are huge variations. And this is knee surgery, which has got a lot of attention lately after a Finnish study, showing that surgery is about as effective as mock surgery. So there is a need to tighten up what we are doing. Yeah, I already said that. Now I come to, I have 5 minutes more? Yeah. Now I come to the instruments that we suggested. User involvement, National Council for Priority Setting should be continued. We think that's a good idea. Someone sitting up there looking at the special fields, the whole country together. And then comes something very important, I think. You may have it in your countries, but a national health atlas to register variation in delivery of healthcare, thereby mapping both overtreatment and undertreatment. Not always overtreatment. Some areas may be treating too few. And that has already been established. The health minister was up in Tromsø in January already. So they have the national responsibility for collecting these important data. And I hope that the politicians will show interest in this data. So also taking the criteria into new technology, as they do in new drugs. One, I think, very important suggestion, and here we have to work together with the universities, is to get more increased awareness on resource issues in education, on all healthcare personnel. When I was educated early, before First World War or something, I never heard anything about resources, what things cost, never. And I think there's a need to get greater awareness. When you're working for your taxpayers' money, you need to know that you spend it well. So, and then the last one is that we suggested some decision support on clinical level. And in Norway, we have clinical ethics committees in every hospital or healthcare trust, and we have also a few in community healthcare. And these are giving advice, not always advice, very often they just are for us which discuss value issues, difficult value issues. But the Commission, and I'm responsible for this work, and I was not the one who suggested in the Commission, but the Commission together said that these forums may be useful, a place where clinicians and patients and relatives can take difficult issues. So that's one way of coming closer to the needs of the clinicians. Next step is that there has been a nationwide hearing process and a vivid public debate. Lots of critique. And the minister is now preparing a white paper for the parliament so they can discuss it and then see if there is a need for new laws. There probably is. They like to vote for new laws in Norway. And the next, what has happened now recently is that the health minister appointed a new commission. So forget everything that I said about the health loss. A new commission will discuss this, and they will deliver their report in November. So I'm very excited to see how they will solve the issue. Anyway, my conclusion is that perfect theory is not enough. And I don't believe that this will come anywhere if clinicians don't take the lead in the work. It is an ethical task for me to avoid hidden and unfair distribution of scarce resources. The strong people will always win if we don't do this well. And we must change the language to reach the clinicians and the public. So there is a pedagogical challenge, a great one, in the media and in the population. Thank you for your attention.
Thank you for this inspiring and interesting talk, which demonstrates that although it might take a long time, ethically sound consideration might have an impact on politics, although you might be skeptical about that. when I listened to your talk, I had the impression, compared to other countries, that you had a quite high impact on the polity and politics setting. So congratulations to that. And I guess there are many questions and comments on that. I had also some, but of course I first give the floor to the audience. Jochen, you were the first. Okay.
It works? Yes, no. Thank you very much for your interesting talk. I have two questions. Could you give us some more examples about the concrete consequences? You said that a lung transplantation is not offered beyond the age of 65. Do you have other examples for these, for such concrete consequences? Because transplantation is a very regulated market. You can say no lung beyond 65, but what about the knee surgery? There are no limitations as such. Do you have other examples? And the second question, what are the consequences for those who are willing to pay? Are the consequences of prioritization only for the social system, or also for those who want to pay for the knee surgery or for the arm surgery? Are they? Do you prohibit surgery on these fields, or what are the consequences?
No, of course we don't prohibit. What did one Swede say? Minister, he said that Norway was one of the last Soviet states a few years ago. But we are not that bad. So and people to a great extent, or not a great extent, but greater extent than a few years ago, they get insurance and buy their way out of the waiting lines. You asked for examples of intervention being denied, and there hardly is any example. We spent, I think, together with the US, I think we spend most money per capita in the world, or in OECD. And old people get new kidneys, my uncle was 90, he got open heart surgery, and fantastic, complicated interventions. Hip replacement and knee replacement and everything. There is no one who are refused. And I think one problem is that we offer, for the old people, we offer technical intervention. We save their lives. Acute life-saving has no age limit. But then we don't have money left for the people, for activities that make life worth living. So nursing care and outdoors activities and stuff like that is rationed, but not acute healthcare.
So we stay there in the back.
Next door here. I noticed that within the three criteria you had, the human value principle was not one of them, which is the most important criteria in the Swedish ethical platform for prioritization. It basically means that thou shalt not discriminate, not for age, for example. And the health loss criterion, let's be frank, it means age discrimination. But maybe we should discriminate according to age. I don't know. I'm not saying we shouldn't, but according to the Swedish platform, we shouldn't. So we discussed this in a meeting this spring, pro and con session with Douglas Lundin. I don't know if he's here today, but he's sitting there. He was for, and I was against the health loss criterion. And we both had strong arguments, and we asked the public. Then they had to vote if they were pro or con. And to my surprise, I thought I was making a good argument and I was going to win that voting. But it was basically 50-50. And when we asked people in the audience, they all had very strong arguments before or against. So it's a very tricky issue, really. I mean, if you ask someone, should we prioritize your grandchild or yourself when you're 70? It's an easy question, but there are more to it than that. So my question really is it okay to age discriminate? Should we do it?
Yeah, it has been, as I said, interpreted more absolute than what the discussion said in the council or in the commission. I think if there is a health gain and reasonable use of resources, you get you will get, as you do today, good treatment, whatever age you have. And in some instances, there is a good reason to prioritize age, an old person before a younger one. If the condition is such that they deteriorate more quickly if they have to wait. But then I completely agree with you. We say that if you are bad off, if you start your life with a lot of suffering and in bad health, and there is something that can be done for you, you should have some priority. And I don't know the answer. Intuitively, I think that has to do with justice and fairness. But I haven't finished my thinking. And as I said, I'm very excited to see what this new commission will come up with. Already today, I think there is some age discrimination also in practice. Children are prioritized in practice.
So I still have 3 on my list, and I'm going to close it, but then after you, no. First we start with Niels Erik. Okay. 5 minutes then.
Mm-hmm. You probably said it, but and forgive me if I missed it, but the Swedish criteria, they are rank ordered. But you didn't talk about that as far as I remember. And I'm curious because your first criterion and your third might well come into conflict. And it feels as something has to be explained there, and you probably do it, and I haven't read what you have written. My second question, which is a swift one, and sounds as if I am an economist, I'm not, is that you distinguish between resources and money, more or less. And you say some resources cannot be put in terms of money. And I want you to give me one example. We don't have an example of that in Sweden, but you must have one in Norway. Give me an example of a resource that is not, I can't say, that resource is worth 25 Norwegian crowns or something like that.
I didn't make a distinction between money and other resources, but I said that scarce resources is more than just too little money. Of course, the reason is too little money in the end. You need more plastic surgeons to educate them, and you need more intensive care beds. But here and now, for all the money in the world, we don't get more plastic surgeons if a child needs some kind of surgery and he has to wait too long. So that's what I meant. The first one was whether the 3 criteria were ranked in some way. No, they should be considered together. But in practice, you will always start with, does this bring a health gain to this person? And if it doesn't, you shouldn't do it.
And when there's a conflict?
I don't know. I don't know. I haven't thought about it.
Okay, then it is you.
I'm Charlotte Smedler from Stockholm University with a long time background for a while in SMER. Thank you very much. I was interested in when you look at it schematically, it sounds as if assessing the health benefit is an easy measure, which of course it isn't. And there is a conflict, correct me if I'm wrong, between the costs of novel treatments. Of course, that's trivial, but we all know that. But with new novel treatments for rare diseases are the most costly treatments. Yet the evidence base for those treatments are also more meager than for more established treatments. So I would like your view on that, because it is as often to assess the health benefit is really very, very difficult, particularly in severe conditions.
Yeah, that was one of the points that the Commission discussed, orphan drugs, and which only a few people suffer from, and it's obviously very difficult to get good enough evidence, and these drugs are expensive. The Commission discussed it for a long time and landed on that orphan drugs should, or rare diseases should not have a special priority, should be treated like any other disease, but giving some, not being as strict on the evidence, but you need some evidence.
Yeah,
that's not in the course of roles and profit.
No, that's true. That's true. That's true.
Kjell Asplund, SMER. Just a comment on age discrimination and the discussion on age discrimination. I was an expert in the parliamentary committee. We had only one commission in Sweden in the 1990s, very much inspired by the first Norwegian one. But I think that one reasoning that has been forgotten, that we extensively discussed, was that the principle of human dignity speaks against age discrimination, but the focus in our lives are a bit different. If we are young or middle age, it's a focus on life-prolonging intervention, and that should be very important. As we are aging, the focus should be perhaps more on alleviating symptoms, increasing quality of life, and that's also accepted by patients, I think. So even if you should have the same right to resources, the resources might be quite different. Perhaps not a knee replacement or cardiac surgery have the same importance in different phases of life.
Yeah, I totally agree with you, and of course, whatever age, if there is something that can help you and alleviate your pain and make you function better, you get it today. So.
Okay. Yeah. So then I would close this session and once again express my gratitude. Although you might not be awarded with the Nobel Prize of Literature, if you diminish, the upheavals might be coming up due to the discussions on healthcare rationing. You are on the road to the Nobel Prize of Peace, and that's closer to your work as you live in Oslo. So thank you very much. And I have the pleasure to invite you, not personally me, but to give the floor for the refreshments, and we have a break up to 12:10. So thank you.